You will pick up my bias fairly quickly. So I think lessons from history is that we tend to emphasize the newer and fancier techniques, and there's no question deep phenotyping with genetics, imaging is very important as you try and dissect down mechanisms of disease and understand disease at a deeper level. But from diagnosing cardiomyopathy in an athlete, actually it's go back to first principles. It's the patient, listen to the patient, talk to the patient, examine the patient, look at the electrocardiogram, do the family history. And that is in many ways where I'm coming from, as you will see. The cardiomyopathies were actually, the concept of inherited disease was actually not really recognized until the late 50s, early 60s. And this gentleman, Paul Wood, was a chain-smoking, hard-nosed Australian who moved to Britain. He probably wrote the best textbook of cardiology. He did it by, on his ward rounds, having his secretary come with him. She took notes, typed it in, and for instance, the chapter on constrictive pericarditis was the last 10 patients he had seen. The chapter on Epstein's anomaly, the last 10 patients he'd seen. This was his observation in 1958. This is before hypertrophic cardiomyopathy is described. And this is an 18-year-old man who'd fainted several times and had chest pain. And he observed that the pulse was of rapid upstroke, that the left ventricular impulse was prominent. There was a palpable atrial beat, which means atrial systole is actually a pressure phenomenon, not a flow phenomenon, so the ventricle is non-compliant. And there's a late systolic murmur. And importantly, there's no click, there's no decreased second heart sound, so this is not aortic stenosis or valvular aortic stenosis. And he writes, this man has some dynamic form of left ventricular outflow tract obstruction without evidence of valvular or subvalvular aortic stenosis. That's actually a perfect description of hypertrophic obstructive cardiomyopathy. And he went on to write, to further understand the mechanism of this obstruction, I would hesitate to give sympathomimetic agents, adrenaline, similar drugs, but any maneuver that alters afterload or preload may be instructive. That's actually what happened for the next 30 years of giving amyl nitrate in the echo lab, giving isoprenolone in the cath lab. Basically, it's maneuvers to alter afterload, preload to examine the magnitude and extent of the gradient. So this observation, 1958, was the first. Interestingly, the surgeon, a very good physician surgeon, Bill Cleland, came by and wrote after this beautifully laid out thing in the case records, this man has critical aortic stenosis and requires valvotomy. And he wrote it, this is all typed, and he wrote it sort of like this across the whole thing. And took him to theater, to the operating room, opened the aorta, and the valve was normal. He stuck his finger across the valve, and there was a very lump of tissue, and he didn't know what it was. He took a bite out of it, which was a myotomy. That was the first surgical procedure. The patient developed a very broad left bundle branch block, but was asymptomatic for 30 years, subsequently died suddenly in his late 40s. But this tissue was examined, and this was the first surgical procedure for this condition. At about the same time, a pathologist, Donald Tier, who was a forensic pathologist, so he's dealing with sudden deaths and is there foul play, observed the features we see on the right here. So this is a myofibrillar stain. So the myofibrils of the myocardium are stained, and you can actually see the striations of the contractile elements of the myofibrils. This is normal. So you see muscle fibers embedded into the stroma of the heart, the connective tissue. And on the right is from an 18-year-old girl who died suddenly, and you see the sort of disorganization around increased areas of loose connective tissue. And if you were electrophysiologist trying to design an unstable electrical circuit that would produce ventricular fibrillation, this is it, because you've got macro reentry potential circuits. So this was observed, and very shortly thereafter families were described and the genes were found. Now this was 1990. We studied a French-Canadian family in collaboration with a genetics group at Harvard, the Zeidmans, and the first gene for heart disease was a spelling mistake, a mutation in beta-myosin heavy chain. And great excitement, 1990, published in a high-profile journal, and this is going to be the beginning of understanding of hypertrophy, remodeling. 30 years later, we're not much smarter. It has not led to the unearthing of clear understanding of disease, that sometimes when you find the gene, it gives you a targeted mechanism to develop drugs, etc. This has been very slow. This is actually quite complicated, and it's been very slow. What has happened is the genes have been recognized, so there's now, I think it's 800 different spelling mistakes in different in the sarcomeric genes. It's all of the sarcomeric genes, so it's a disease of the thick and the thin filament myosin. Most of the mutations are in beta-myosin heavy chain, which binds to the troponin tropomyosin actin complex. And these all produce a small amount of disease, but this and myosin binding protein C produce most of the disease, probably 85 to 90% of disease. So clearly it's defined as a disease of the sarcomere. What are we targeting? Well, I think a nice way of looking at this, you will be familiar that, if you want to win the Olympics or the Oxford-Cambridge boat race, the bigger, stronger these studs, the more chance of winning. However, what's more important is how they work together. And if you go back to the muscle, to the sarcomere, if you've got, for argument's sake, 50% wild type or normal myosin, and you've got 50% mutant, you have a different force velocity profile. So what happens is you get this crisscrossing, you get force velocity developing, and the disorganization, disarray. And it becomes inefficient. You're using much too much energy for what you're doing, too much glucose, oxygen, and you get a compensatory hypertrophy. It's very much the same as Duchenne's muscular dystrophy with, you see the 9-year-old boy with the calves that look like he's been playing for Manchester United for the last decade. So this is the working hypothesis. There's a lot of data to support the concept, but we still don't have a targeted mechanism to treat. And there's a guy in James Spodek in Stanford has a laser tweezer where you can measure the force velocity developed by a single myosin molecule. And there are drugs which are being developed to either upregulate or downregulate myosin for dilated and hypertrophic cardiomyopathy. But this is just the beginning of what's going to happen, but it's been very slow to develop. In terms of the athlete, what are we worried about? Well, I suppose you're worried about this, and you're also worried, could continued athletic participation lead to disease progression severity? Most of us, worry about, as you get to a certain age, you worry about your prostate. Younger, you worry about breast cancer and whatnot. With the athlete, we're not looking at acquired disease. It's as you'll recognize, we're amazingly resilient. It's hard to drink, drugs, smoke, eat your way into oblivion in your 20s. You can do it with drugs, but even eating, drinking, and cigarettes in your 20s is hard to really put yourself into oblivion. So there has to be something genetically wrong, and that's really what we're looking at. So a very clear message. Yes, it's lovely to find genes and to try and understand at a genetic level, but a good family history is a poor man's gene test. And I think that's still, and I'll come back to this in my last slide, that still is very, very valuable, is actually getting a good family history. In terms of sudden death in the athlete, I'm going to touch on all of these things, but clearly in the time available, I'm not going to be comprehensive. I'm going to give you snapshots of the magnitude of the problem and the causes. Question, are athletes at increased risk? Is an athlete, just by nature of what he's doing, at increased risk? Do the screening programs work? And you'll be familiar with Domenico Corrado, who is the advocate, and the Americans who are anti the screening programs. What are the logistics of how you evaluate a patient? And once you've evaluated, what do? Do you just tell them to stop exercising? There must be a better management program. So what actually can you do to prevent events? This is the list. And this is a summary, but basically, historically, this has been said to be the commonest cause. It definitely was in the 1980s, 90s. The community is very aware of this condition, and it's actually quite easy, as I'll show you, to diagnose with an electrocardiogram and an echo. There's clear criteria. And I think we've actually, as a community at large, largely preventing this through screening ECGs, screening programs, increased recognition by cardiologists, general physicians, general practitioners. This, and the Italians say this is the most important. They're probably correct. Not statistics, they're probably correct because we don't recognize it. And you can have a good pathologist receive the heart of a 20-year-old who's died suddenly, and the pathologist misses the diagnosis. So it's not straightforward, even when you have the whole heart in your hand. Coronary anomalies they're hard to know, because you see them in a lot of people, and you don't know whether to what extent they are determinants of death. But they're clearly important, and there's particular definitions of which ones, the way the angle of the way the coronary comes off the aorta, etc. My bias, even though I'm a cardiomyopathy man, is that the inherited arrhythmias are probably more common as causes of events than we recognized in the past. And these are all fairly obvious, and these are small print. So this is what we're talking about today. But my bias is that these are probably equally important. The literature's confusing because the Americans say sudden death in the young. These are rare events, and they do cost-benefit analysis to show if you do screening, you're going to have to screen millions to pick up a few people. Probably the best proponent of why screening is valuable is Domenico Corrado from Padova, and I'll show you more data from him. Probably the most accurate number is probably from this study here. So, and it's very hard, you're comparing apples and oranges. So if you're talking about deaths in 70-year-olds from infarcts, that's very different than a death in a 20-year-old from anything. And our statistics, the way health systems work, they don't actually make the differentiation. And if anybody, when you deal with families who've lost a child, it's basically the worst thing that can happen to you. In contrast, if you lose your father or your grandfather when he's 75, well, it's sad, but he's lived his life. So the measuring the impact of these deaths is actually very difficult. This is the data from Corrado. So first of all, it's published in JAMA, which is actually a tough journal to get into. It's a journal where the methodology is very stringently reviewed by the methodologists, the statisticians. So here is an sudden death per 100,000 person years. I always find these sort of constructs difficult. What does a person year mean? We know age, we know sudden death per year, incidence, prevalence. Anyway, this is the way he's presented his data. They start their screening program in Italy. You'll be familiar probably, but in Italy, by law, you have a sports medicine industry, which by law, you have to be past fit every year from the age of 12 with a certificate from a sports medicine doctor who says you're fit to play. And that you have a physical examination, an electrocardiogram, and a little step test where sort of an old master's step test where you go up and down off a box. It's a kind of a limited exercise test. Everybody has that. So the Padova group collected all of this data beginning in 1979. This was in the athletes. They were 3.5 sudden deaths. And they started the screening, and during this period they recognized hypertrophic patients whom they removed from athletic participation. During this period they recognized the arrhythmogenic right ventricular cardiomyopathy patients as they've continued, and they would say that now the athlete's sudden death rate is actually below the non-athlete's sudden death rate, which has maintained stable throughout the years. It's an abnormal ECG, and you need to be very clear what that is, and it's not a peak T wave or a J point elevation in an athlete, it's this. Interesting anecdote is 27-year-old squash player, third in the world, bends over at a bus stop to tie a shoelace, passes out. Ambulance driver is going by, sees this, loads him in the ambulance, takes him to a hospital. In the hospital, his blood pressure is 60 to 80 systolic, and his heart rate is 25 to 35. He doesn't change overnight. He's in a coronary care unit. In the morning, he says, I want to sign myself out. The hospital says, no way, so they ship him to us. He's a foul-mouthed Australian. Everything's a four-letter word. And he's not happy to be moved from one hospital to another. We do ECG echo exercise. This is the ECG. His echo is 1.4 centimeter concentric hypertrophy. It's not normal. Very borderline. It's not diagnostic of hokum, but it's not normal. And this electrocardiogram is not normal. And yet, his peak oxygen consumption was 75 mils per kilogram per minute on a bike. And at the time, and whenever this was, that was the highest we'd seen at that time. Gomez Noya's higher, but you have to be a very elite endurance athlete to get up into that range. So he's very, very fit. And our bias, and based on data, was that the elite athletes who have the elite athletes who have hypertrophic cardiomyopathy do not have peak VO2s. You can play professional football and not be all that fit. You can compensate, and there's some people who are very fit, but our bias based on data was that this was not compatible. So I use this as an example. The rule is an abnormal ECG is abnormal, but there's always exceptions to rules. And I presented this once at the Dutch Football Association, and I presented this as the last slide of the example of breaking the rule. And we're at the coffee break, and this lady came up to me and she said, "That's so-and-so." And she was right, she named him. I said, "How do you know that?" And she said, "I was at the World Championships in Islamabad." And she said, "I hadn't seen him for a year. He's changed completely. He's got acne. He used to be a very pleasant guy. Now he's all four-letter words. He's beefed up. And that's an anabolic steroid user." And of course, she was absolutely right. That's exactly what this is. Now, we as a community, we're not, us, Mariangela, as cardiologists, we're not expert in picking up the different ECGs based on the drugs, because they never tell you the truth anyway. But this is part of the spectrum of these elite athletes when you're trying to assess cardiac disease. If we turn to the conditions that we're worried about, at least for this morning, it's these three: hypertrophic, dilated, and arrhythmogenic cardiomyopathy. This classification was the same in 1960. What's changed is the emphasis on the familial basis and genetic basis. And sometimes you strike out. Somebody doesn't know who his father was, or you can't access the parents, or you can't figure it out. But this is what you're trying to do, is define the phenotype, assess the family, and find the gene to understand the genetic subtype. In hypertrophic cardiomyopathy, it's actually very, very straightforward. And the diagnosis is the demonstration of unexplained left ventricular hypertrophy. The electrocardiogram shows it, the echocardiogram measures it, and so this is the diagnostic criteria, and this is an alternative magnetic resonance. The ECG is abnormal in 95% of individuals. So if you have somebody that you think is hypertrophic and the electrocardiogram is normal, be very suspicious of the imaging if the imaging is telling you it is. And if the ECG is normal, by and large, you can say you're fine, you do not have hypertrophic cardiomyopathy. And if your parent had it, it doesn't mean you won't develop it later, but you don't have it now. And these are the changes that one sees. Very importantly, actually, in the athletic community, and here there's often you see individuals saying they think he's got hypertrophic cardiomyopathy because there's voltage criteria for left ventricular hypertrophy. That's actually a sign that it's much more likely to be a fit, healthy young athlete. So as an isolated finding in hypertrophic cardiomyopathy, voltage LVH, you don't see that. And there's a nice paper from us, Sanjay, Policia, and Corrado on this in Circulation. This is a sort of, hypertrophic cardiomyopathy is queer because there is no typical, and the typical is atypical. So when you see a funny electrocardiogram, it's usually sort of multiple infarcts in an older patient, or it's hypertrophic cardiomyopathy. And here's a fairly typical example you can read. But there's it's hard to see, but there's pathological, very bizarre Q waves in lateral leads, left axis deviation, and it's abnormal. More typical, is the standard left ventricular hypertrophy with repolarization changes that you would see in any form of left ventricular problem. So this could be aortic stenosis, it could be dilated cardiomyopathy, could be hypertrophic cardiomyopathy. In this case, it's a 19-year-old medical student who's got severe, roughly 3 centimeter asymmetric septal hypertrophy. He's got systolic anterior motion. He's got a gradient. He's quite interesting because his uncle is certainly the most controversial and one of the 2 most successful cardiac surgeons in the UK. And he says, my nephew needs an operation. The mother, who's a GP, says there's no way Uncle so-and-so's operating on my boy. The father's an academic gastroenterologist who sort of opens and closes his coat and says, well, it's very difficult, maybe we should get a second opinion, and So anyway, and the surgeon says, and he said, well, I'll go and assist whoever. I'm the only guy who can do it. And I said, no. We ended up operating, and it was successful. But the surgeon insisted on coming to help our surgeon do this, which, you know how surgeons like help from people they don't like. A lot is made. There's a whole industry about writing papers around differentiation of the gray zone, the athlete from the hokum. It's a nice way to write a paper, but it's actually very straightforward. And the changes, the hypertrophy and hypertrophic cardiomyopathy develops at the expense of the left ventricular cavity. In contrast, the hypertrophy that develops in an athlete develops to enable you to have a larger stroke volume. So the cavity size is a very important, and that's something you can measure accurately. So this is a key one. The ECG is the other one, and of course the family history. If it's an athlete with a family history, he's got a 1 in 2 chance. If there's no family history and the parents are normal, then he's got a 1 in 500 or 1 in 1,000 chance. So this should not be a difficult arena. Quite important, and this is not in the literature, is the fact that we think of hypertrophic or long QT, right ventricular cardiomyopathy, and we think of a full phenotype, long QT, the QT interval is extended. Most of these people who carry these genes are non-penetrant. So he's got the gene that his father has, but he has a normal echo, or he's got the gene his mother has, but his QT interval is normal. And we don't know what the level of risk is for a non-penetrant or incompletely penetrant disease. To emphasize this is the first family that we found a disease gene in. This is the French-Canadian family, and we tracked them back to Normandy, Brittany, where they migrated to Quebec in the 1690s. And the Catholic Church in France and in Quebec kept marriage, birth and baptism and marriage and death records. So you were able to track through the churches all these generations. And in this family, this was the gene. So you've replaced the glutamine, an arginine for glutamine replacement at the 403 codon in beta-myosin heavy chain. We had 53 individuals with this spelling mistake, and all of them had an abnormal ECG and abnormal echo. So completely penetrant, nobody non-penetrant, nobody incomplete. And this is sort of circa 1990. Studying the family, great success, and we at that time didn't recognize very clearly that if you had the gene, you must have the disease. Well, all of a sudden comes another beta-myosin heavy chain mutation, glycine to glutamine substitution, and of the 34 gene positives, roughly half had a abnormal echo, and the other half, normal echo, half abnormal, and these all had a normal ECG. So all of a sudden we have normal echo, which is usually what we rely on to diagnose, and abnormal ECG. So what are these people? And of course, they're incompletely penetrant. And even more so, here is troponin I, 96 patients, and more than half of them normal echo and normal ECG. So you would say, troponin I is mild disease. No. In the troponin I families, they're very different. You can have grandmother, very mild disease, daughter, an abnormal ECG, normal echo, and then a 12-year-old grandson who's got 4-centimeter concentric hypertrophy and needs a transplant. So the expression within the family, there must be other genes, environmental factors, but probably other genes that are influencing expression. But the important thing here is that you don't die suddenly with a normal echo. So we have no examples from myosin troponin I or myosin binding protein C of a sudden. There's one publication from Arthur Vilda, and the guy probably had another disease as well. So evaluating is quite important, the non incomplete expression. The exception, however, is if you've got a mutation in troponin T. This is a family we published in the late 90s, and these 4 individuals died suddenly at the age as shown, so young, and they all had myocyte disarray. And actually, this was the girl I showed, whose heart was 40% of the left and right ventricle showed that disorganization. myocyte disarray, premature sudden death, but no left ventricular hypertrophy. So the heart weights were normal. So you assume if we'd seen these people clinically, and just did echo, we would have missed them, probably. We looked at these two and we felt they were normal, but this girl we felt was probably affected. This is her, oh dear. Well, it's a normal echo. And so she has a normal echo. Maybe a little bit of thickening towards the apex, but thickening 11 millimeters, not diagnostic of anything. And she's normal size. But this is her electrocardiogram. So T-wave inversion, V1 to V6. So this undoubtedly reflects the gene that killed her sister, cousin, mother, and aunt. And yet she doesn't fulfill diagnostic criteria. So here is a worrisome scenario, because you can go to the doctor who says, oh, your echo's normal, you don't have hypertrophic cardiomyopathy, you have an abnormal ECG, and die suddenly. So this breaks our rule, and this is, it's probably very rare actually, but this is worrisome, it's the troponin T disease, and it's one of the reasons you should at least have some limited genetic screening. It also highlights, if you're in the kind of business that we're all in, of looking at athletes, of recognizing that T-wave inversion with a normal imaging, that it's not acceptable to say, oh, he's Afro-Caribbean, it's a racial variant, or this is physiological sort of heart adaptation, athlete's heart. And the athlete's heart concept that emerged in the 70s is very confusing now. This is probably incomplete expression of one of these genes. It may be incomplete or inadequate imaging, or it could be performance-enhancing drugs. And this is obviously more difficult to figure out. But this is the diagnosis of the destitute. I would not accept these as diagnostic criteria when you're seeing this kind of T-wave change. So incomplete expression, it's not in the literature, it's not that well emphasized, but it's probably 50% or more for all of the inherited diseases. A quick clue, and Maria Carmel will recognize, when you see this giant T-wave inversion, that tells you immediately that there is some form of apical disease. This is the echo of a young person who was referred. This is the echo from the referral hospital. Very easy to turn your nose up and be critical. It's a terrible echo. This is echo from our hospital. You can turn your nose up again because it's not very good, but that tells you probably not an easy echo subject. But you're suspicious that down at the apex there's something. When you do contrast, you see that there's apical obliteration, there's apical hypertrophy, but it's not readily apparent. The clue is actually here. When you see the T-wave inversion, the deep T-wave inversion, you've got to go looking with either contrast or magnetic resonance imaging. A lot's been made of magnetic resonance as the way to do this. We understand the artifact in echo. Most cardiologists trained with echo. Magnetic resonance, we're learning. We're on a learning curve. But this is a publication which purports to show that this is the way to diagnose apical hypertrophy. And if you look at these two images, this looks like apical hypertrophy. This looks like apical hypertrophy. This is the mitral valve. This is the mitral valve. The mitral valve is closed. That means you're into systole. So that the ventricle has contracted. You must be 40 to 80 milliseconds into systole. Mitral valve is shut. So if you want to measure biceps and it's not contracted, it's very different than if you contract it. This muscle is contracted. The measurement should be done at end diastole, and they're not the temporal resolution of MRI and the way the MRI doctors do it. This is very often overemphasized. So we're getting better, and this was 2004. So we're learning, but I'm not sure that I agree that this is always the best way to diagnose hypertrophic cardiomyopathy, and you need to be aware of the artifact of this technique as well. This is top 500, 600 in the world tennis player. And again, the signal is here. There's an abnormal ECG, giant T-wave inversion, and here's his echo. And you begin to wonder, down here, is there thickening? But this is all very subjective, and this is no clearer to me than it is to you. One of the things that we've recognized, however, is that what you get You don't have to fulfill diagnostic criteria. It's the relative hypertrophy. Normally the base is 3 to 4 millimeters thicker than the apex, but in this patient, in this young tennis player, they were all these measurements are the same, and that's what gives you that discrepancy on the electrocardiogram. So it's not necessarily the hypertrophy, it's the relative increase in thickening relative to the base. Very briefly, in watching the time here, the condition which is trickier is arrhythmogenic right ventricular cardiomyopathy, and here, this is the characteristic presentation: a left bundle branch block, tachycardia. So it's coming from the right ventricle if it's got left bundle branch. And these people often have syncope on exercise. If it's syncope after exercise, that's very unusual. That's hypertrophic. But if you get syncope during exercise, that's long QT, LQT1, or ARVC. This is the pathology where the fat replacement from this is the epicardium. So it's a disease of the outside in, of the epicardium, with fat, fibrous tissue replacing muscle cells, and usually sparing of the inner layer, the endocardial layer of muscle. And here you see a great chunk of fat that has replaced muscle. Actually, you don't know that. You see a great chunk of fat. And the question is, has this replaced muscle, or is this just the fat that we carry around where we don't like it? And we don't know. Even a 25-year-old will have chunks of this in his right ventricle, so it's not diagnostic. Or it is diagnostic. Here you see scar engulfing engulfing myocytes that are in the various stages of cell death, whereas here you see completely normal myocytes. So you've got fibrous, fatty replacement of dead or dying myocytes. That's the pathological diagnosis. The first gene for this condition came about because these two individuals, Nikos and his wife Adelena, sent to the Greek island of Naxos to do their medical service, and we would love to go to Naxos for a holiday. They didn't. This is no medical facilities, and this was not where they wanted to be. First month they were there, an 18-year-old died suddenly, and he had sort of kinky afro hair and scars. He had palmar plantar keratosis on his hands. They wrote to every professor of cardiology in the world, and they didn't get a sensible answer from anybody. This was early 80s, about cardiocutaneous. So, have you ever seen, dear professor, heart disease with skin disease? What do you do when you don't know? Either you don't answer or you say no. They studied this family, and when we were involved with the first gene for hypertrophic, they gave us the privilege of actually studying this family. And we found gene abnormality in plakoglobin. Sorry, it's here, up here on the left. And that led to understanding that this is a disease of the desmosome. We found mutations have been identified by us and other groups in all of these genes. And this is one cell, so this is the cell membrane. This is the gap junction, so the electrical transmission of cell to cell. This is the cell membrane of an adjacent cell. So you've got, it's like there's bricks and the cement in the middle. You've got structures, protein structures that embed across. And the spelling mistakes are in either these genes, or the genes that encode these proteins, or the genes which link to the structural elements within the cell. So it's the structure that binds cells to cell within, but for electrical transmission. Quite, probably more scientific than you want, but it's quite nice. With hypertrophic, we really didn't have any way of studying the disease here, and this is just one example. You can get tissue. It can be old, formalin fixed tissue, and you can do immunohistochemistry, and this is the gap junction. So this is a normal gap junction. So you can see that the proteins for which you're looking at are localized in the gap junction. If you do your control, you see here, this is from the Naxos family, and here you don't see it any, and yet if you look at the Western, you see that there is protein, but it's in the wrong place. And when you look at the C-terminal end, which is where the mutation is, you don't see any. So this protein is it's actually moved from the gap junction into the cytosol, and it's in the wrong place. So it's a kind of haploinsufficiency. The protein isn't there, but there's zebrafish work which has looked at this and identified compounds that can actually move the protein into the right place and abort the phenotype. So this is in probably not quite phase 1, but close. The diagnosis is actually, once you are thinking about it, the ECG is abnormal, the echo is abnormal, the MRI is abnormal, left bundle branch block VT, sudden death risk. It's not that difficult once you, and in fact, because there's uncertainty, there's too many people make the diagnosis of this incorrectly. But it's not that complicated once you think about it. There's diagnostic criteria. This is a multi-center group, and it just shows that whenever you see, scoring systems, it's not straightforward. The last point I wanted to make is in relation to dilated cardiomyopathy, and clearly this isn't going to be an elite endurance athlete. This is somebody with severe dilated cardiomyopathy. You see contrast wiggling around, so there's risk of embolus coming out, very severe. Our understanding of this is interesting. It depends on when you went to medical school. So many think it's a virus. Some think it's an autoimmune disease. In this century, it's a genetic disease. And of course, all of this is correct. There's various triggers. So if you have an underlying genetic weakness and you get a viral infection, or you stress it with alcohol, or pregnancy, or endurance training, you can activate a pathological process which becomes self-activated autoimmune, leading to a dilated cardiomyopathy. So all of these things are relevant. The genetics, it's a disease of cell structure. So this is a cell, and the structure this is the cell membrane linking to the extracellular matrix. So you see mutations in the sarcoglycans dystrobrevin complex. You also see mutations. We think of this as the sarcomere as a contractile, but if something's contracting, it has to be fixed. It has to have some structural elements. So these have structural elements in them. And the list of disease genes is shown here. And some of them are cytoskeletal sarcomere, but this is structural. But these are arrhythmic genes. And question mark, to what extent does sudden death occur in dilated cardiomyopathy? To what extent are these arrhythmic genes being missed? To what extent is someone with dilated cardiomyopathy at risk of premature sudden death, not when he's waiting for a transplant, but when he's actually active and working? Here's a family that we published in Circulation in 2005. This young man died suddenly, and the pathologist, Michael Davis, said, this young man has some form of cardiomyopathy which appears to be the same as right ventricular cardiomyopathy, in that there's fat and fibrous tissue in his left ventricle, typical of ARVC, but there's none in the right ventricle. And he writes, is this some form of left ventricular ARVC? Until we find the genes, we won't know. Well, we were able to find the gene in the family. It's a desmoplakin gene, and we studied the family. We found 11 members of the family had the particular spelling mistake shown here. And this was the ECG. So this is a left ventricular ECG. T-wave inversion, V3, V4, V5, V6. This is, on a multiple choice exam for your boards, if you're given a list, is this least typical of ARVC, aortic stenosis, dilated cardiomyopathy, hypertension, hypertrophic cardiomyopathy? This is not ARVC because it's left ventricular. And yet, that's one of the ARVC genes. So these genes can cause left ventricular disease. And in the family, there were 11 family members. Here is this one particular lady who was in her 60s. This is her MRI. This is her LV, which is completely normal contraction pattern. This is her RV. Now that looks like a wall motion abnormality right there, and it is, but that's where the moderator band inserts. So that's a normal finding in a right ventricle. This, when you see this, you wonder, but if you do multiple views, this was entirely normal. But this lady's MRI, in terms of structure and in terms of function, was completely normal. But here's her late gadolinium. And here you see scar at all levels of the ventricle in her left ventricular posterior wall. And we found that in the affected individuals. So they had abnormal ECG with arrhythmias of left ventricular origin, ECG changes left ventricular origin, and late gadolinium. So this is, if you will, an arrhythmogenic dilated cardiomyopathy. And when you're taking a family history, when you're seeing an athlete, That's a key distinction. Is this heart failure dilated cardiomyopathy caused by these genes, or is it an arrhythmic dilated cardiomyopathy with sudden death in the family, VTVF, conduction disease, a pacemaker at a young age, atrial fibrillation at a young age, caused by these genes? And it becomes very important. That family history in the young athlete is actually very, very important. And that's back to my first point, is the MRI is nice and the genetics are nice, but actually, in actual fact, this is vital information. Do you have anybody who's got a pacemaker at a young age? Anybody die suddenly? Anybody with skeletal myopathy? Any associated phenotypes? This is actually where the money is. We know a lot about these genes, and this is beyond the scope of this, but there are specific genotype-phenotype relationships to these genes. So once you become suspicious, then you can get expertise involved around the genetics, and you can usually work out exactly what it is. So in summary, in terms of diagnosis in the athlete, when suspected, history, serial ECG, family history and serial ECG. Important to recognize that, define what is an abnormal ECG and not accept it as, well, he was an athlete or he's a marathon runner or whatever. And in the absence of a clear phenotype, you shouldn't do gene testing, and I'll show you one last slide. This is sort of covering genetics in about 3 minutes, which is not possible, but if you go back, and I've mentioned genetics and genes, and you say, well, should we be doing gene testing? First gene, 1990 for heart disease, and the original approach, great excitement. You have a sequence analyzer which looks at a sequence, and you're looking for spelling mistakes. The original sequence analyzers could measure 300 base pairs. Myosin is 30,000 base pairs, so that's one gene that causes hypertrophic cardiomyopathy. So just to screen for myosin, you're going to have to run that machine 100 times. If you dial your own telephone number 100 times, you'll make a mistake. So there's an error, and it's not cost effective. It was not cost effective. So gene testing, despite the efforts of various promotional groups and venture capital teams, gene testing has not taken off for a variety of reasons, but largely the technology wasn't there to do it. The last 4 or 5 years, you've got next generation sequencing. Now you can measure 1 million base pairs. And so you can do the sequencing. Now the problem is, what do all these spelling mistakes mean? Because if you sequence any one of us, you'll find 80,000 spelling mistakes that are different from the control populations. Okay, you can use in silico programs and different things and get down to maybe 8,000 from 80,000, but you're left with a bunch of spelling mistakes. And a good example, say you take the word receive and you reverse the E and the I. It's a spelling mistake, but you know exactly what the person means. You just know he can't spell, but you know exactly what he means. That's a spelling mistake that probably doesn't change the encoded protein. It probably doesn't cause disease. Say you take the word fat and you put a little squiggle under the F and make it into eat. That completely changes the sense. And when you get those kind of spelling mistakes, it changes the code. And our problem with the analysis of the data right now is we don't know which spelling mistakes are important. And I say we, I mean the whole community doesn't know which spelling mistakes are important. But this is just a matter of bioinformatics, big computers. It's happening and it will happen, but I don't think we're ready for prime time on gene testing. So I use the analogy here of the car. The gene testing is transformative, disruptive technology, just like the automobile ended the horse and buggy era. This was a random event. If you really wanted to make sure you got into town to pick up the flour and sugar, you took your buckboard, because this may not start. It may overheat. Front axle may break. It may get stuck in the mud, whatever. The goal, and this were all built by man, individually. Automation came in, Henry Ford, 1920s, an assembly line, you're producing a gold standard same. This is about where we are. We're just about getting to a gold standard for performing and gene testing in terms of the interpretation, but we're not here where we have the household car as or the car as a household commodity that we take for granted. So gene testing is, I think it's close, but we're not quite there yet. And there's very specific instances where, from the athlete's standpoint, particularly with troponin, you would want to do it. Thank you.